very excited. My name is Alan Schroeder. I co-direct this COVID in Children seminar series with Dr. Rodney Matthew from Pediatric Infectious Disease. And excited to have Hayden Schwenk speaking to us today about COVID-19 therapeutics. And Dr. Matthew will introduce Hayden very shortly. On December 3rd, we will have a session on COVID and the heart, sponsored by some of our pediatric cardiology colleagues. And then on December 10th, before the holidays, we wanted to have a COVID-19 open forum. This is going to be an opportunity really just to ask questions of these two wonderful pediatric infectious disease physicians that have been so helpful throughout the pandemic. So we will actually have an opportunity to submit questions in advance. We'll have a series of questions about the vaccine, about transmission, about all the other things that have come up in some of our prior sessions that we've run out of time to answer. So that will hopefully be a useful session. We try to do every week. We begin these sessions with a 5-minute evidence quick hit presented by one of our trainees. I want to compliment Dr. Joshi for pivoting last minute on this one. She was going to present a pretty cool article in Science that I can put in the chat that was about sort of cross-reactivity of immunity from other coronaviruses to this coronavirus. But then this was published yesterday, and this has become such a highly politically charged question that it's been really fascinating to see the reactions from both extremes, with people on one side saying that this is a study showing that masks don't work, and people on the other side saying it's a totally useless study that should never have been published. And so we thought it was worth spending 5 minutes. And Dr. Joshi is one of our pediatric hospital medicine fellows who was previously a pediatric neonatal hospitalist and has done really cool work on babies born to moms with chorioamnionitis, and today is going to tell us about this study that was just published. Thank you, Neha.
Perfect. Thank you for the introduction, Alan, and thanks for having me. As Alan mentioned, I'm here to share with you a study that was just published yesterday in the Annals of Internal Medicine titled Effectiveness of Adding a Mask Recommendation to Other Public Health Measures to Prevent SARS-CoV-2 Infection in Danish Mask Wearers, a Randomized Controlled Trial. The question that this study was asking was, does recommendation to wear a surgical mask outside of the home reduce the wearer's risk for SARS-CoV-2 infection in a setting where masks were uncommon and not among the recommended public health measures? The study took place in Denmark from April 3rd to June 2nd. Of note, April 3rd to April 24th was the recruitment and the randomization period of this study. And so the true intervention came about between April 24th as well as June 2nd. At this time in Denmark, there was no universal mask mandate, and less than 5% of the community was wearing masks outside of a hospital setting. The recommended public health measures included social distancing, frequent hand hygiene, and limiting the number of people seen, and indoor dining was closed until May 18th. There were 6,000 adults that were randomly assigned to one of two groups, one which is a mask intervention group, and two which was a control group. In order to qualify for the study, the participants must spend 3 or more hours outside of their home daily, and they must work in a place that does not have a mask mandate, such as a hospital setting. The intervention group was given 50 surgical masks, and both groups were given information on social distancing. Both groups are asked to self-administer antibody testing at baseline in 1 month and have a self-administered OP or NP swab for a PCR at 1 month. The results included that the mask group had 1.8% infected at the end of the 1 month period of the study, and the control group had 2.1% infected at the end of the 1 month study. Let's discuss these results a little bit more. So the mask adherence amongst the intervention group showed that 46% reported that they adhered to the mask guidelines exactly like they were instructed to. 47% said that they predominantly adhered to them, and 7% said that they did not adhere to them. The intervention group had 42 infections, which is the 1.8% we just saw, and the control group had 53 infections, which is the 2.1% that we just saw. These figures together made an odds ratio of 0.82 with a 95% confidence interval of 0.54 to 1.23 with a p-value of 0.33. The authors reported this as, although no statistically significant difference in SARS-CoV-2 incidence was observed, the 95% confidence intervals are compatible with a possible 46% reduction to a 23% increase in infection amongst mask wearers. Multiple sub-analyses and sensitivity analyses were done. These are the ones that were done listed here. And there was no change in the direction of overall findings in any of these 5 analyses. This included imputation for missing data due to loss to follow-up, excluding the 7% of those who said that they did not adhere to mask wearing in the intervention group. Including only the 46% who said that they wore masks exactly as they were recommended to. Excluding the group who tested positive at 1 month but did not provide any baseline testing. So this is basically assuming that this group had tested positive at the baseline of the study. And so they tried to exclude all of these people as well. And lastly, they excluded those with no baseline testing. None of these 5 showed a change in direction of the overall findings. So my thoughts on this study is that it is an inconclusive study, but it adds yet another piece to the puzzle. It's important to note that this study was designed to assess the protective effects of masks to the wearer and not source control, which is preventing the spread of infection to the others. And source control is what we are assuming to be the predominant mechanism for reduction of transmission in those who are wearing masks. Also important to note that the question that was being studied was whether the recommendation to wear a mask reduced the risk of infection and not directly studying the mask itself. As Alan mentioned, the study has been all over Twitter and people have been up in arms about it, saying that it's pretty irresponsible for this journal to publish the results that can be misused by those who are opposed to mask wearing overall. And I agree with the editors when they said, we think not. What would be more irresponsible would be to not publish the results of a carefully designed research because the findings were not favorable or definitive as we would have hoped. The limitations to the study include that the baseline risk between the 2 groups was not discussed. So what were the occupations and what was the time spent outside of their home for people in either group? That the antibody testing and the PCR testing was both self-administered. That the study period of a few days may limit the detection of all infections because of what we know about false negativity at the beginning of an illness. And lastly, that there's multiple threats to external validity, including that the participants may have been more vigilant about hand hygiene and social distancing than the overall population, and that these results may not be applicable to a community where most people are masked. So my conclusions are, from this study, in a community with minimal mask use, we cannot statistically exclude no different protective effect between a group recommended mask usage versus not recommended mask usage, and that we need more studies. Thank you.
Thank you so much, Neha, for that excellent presentation. Obviously, another controversial study, but I think that's what we've been learning throughout this pandemic, and it's always interesting to see another side to this conversation and always challenging us to think about it more and more. But thank you so much for your excellent presentation. We'll now move on to our session on therapeutics. Kindly put your questions in the Q&A, and depending on the amount of time we have remaining in the hour, we will address them at the end. It is my pleasure to welcome my friend and colleague, Dr. Hayden Schwenk. He's a clinical associate professor in pediatric infectious diseases at Stanford. He is also the director of the Antimicrobial Stewardship program at Lucile Packard Children's Hospital. He's also the co-chair of the Pharmacy and Therapeutics Committee at Lucile Packard Children's Hospital, and hence is very much involved in all therapeutics decisions for COVID-19 at our hospital. And we couldn't have chosen a more informed presenter for this topic. And we welcome you, Dr. Schwenk.
Thank you so much, Roshni, for that introduction. And thank you to the organizers for having me here this afternoon. So today I'm going to be talking about COVID-19 therapeutics. Just so that everyone has a sense of where we're heading for this talk, the outline for the presentation will be a little bit of background about therapeutics for COVID-19, some important treatment considerations, particularly as we think of the use of these medications in children. I'm going to run through a couple of specific therapeutics that have been studied, including remdesivir, steroids, bamlanivimab, and hydroxychloroquine. And then I'm going to wrap up with a reference to our Packard-specific practice guidelines that have been developed. So just to kind of set the stage, this was data that was released by the AAP last week, and I think is really helpful to organize our thoughts around the problem of COVID-19 in children. So to date, there have been over 1 million cases of COVID-19 in children. And we are seeing an increase in the number of child COVID-19 cases more recently. In the last 2 weeks, there's been a 22% increase in that in the number of cases. We do know also that children represent a very small fraction of the total COVID-19 hospitalizations, right now estimating to be 1.2 to 3.3%, and an even smaller fraction of all COVID-19 deaths. Thankfully, the rate of death in children with COVID-19 is very, very low. This sort of sets the stage in terms of thinking about the natural history of this illness in children. What we know, and if I'm going to make some generalizations here, is that the acute disease manifestations tend to be less severe in children. That is, that children tend to be more likely to have asymptomatic or mild to moderate infection. As a result, the hospitalization rates and the need for ICU care typically are lower in children. And I'm giving you data that was compiled by the CDC to give you a sense of the rate of hospitalization in children 0 to 4 and 5 to 17 versus those young adults 18 to 29 years of age, as well as the rate of death. And just so that people have a sense of comparison when we're thinking about our particularly high-risk populations, like those over 65 years of age, there's a significantly higher rate of both hospitalization and death. That being said, we do know that some children will go on to develop severe disease. And although there are no definite risk factors that have been established for children in terms of identifying those children who are at greatest risk for severe disease, we've certainly seen patients who have been hospitalized or need ICU care. And as I referenced earlier, there have been deaths among children with COVID-19. But this presents a lot of really interesting therapeutic challenges that are particular to children. The first is that we know that there's relatively little evidence that's looked at potentially active antivirals for the treatment of COVID-19. And I am going to walk us through some of what has been published and what has been studied. But this is a relatively new disease. And obviously, the therapeutics will lag behind that somewhat. Obviously, things are moving very quickly, but still don't have a ton of data. The other problem we have when we're thinking about children is that most clinical trials have focused exclusively on adults with COVID-19. I've listed here a couple of examples of trials that have enrolled children. I am going to walk through some of these. Some of them have included children of any age. Some have included children who are at least 12 years of age. But obviously, most of what we're operating on is the data from adults with COVID-19. And as I mentioned earlier, it's something that we have to take into consideration because most of the time COVID-19 will be much more mild in terms of the severity of illness in children than adults. And we have to think about how that shifts our risk-benefit calculation. If we know that most children will do well and at the most experience mild to moderate illness, what do we think the expected benefits are of the therapeutics that have been developed? No intervention that we do, and I think this is something that's often not at the forefront of people's minds, but is a significantly important consideration is what are the risks? And if we think the benefit is marginal, I think those risks become even more of an important consideration. And I think the one other point I'd make is that for every dose, for every vial of one of these medications that we're using in a child, that's one dose or vial less for an adult patient in whom there may be an evidence base to support efficacy, and in whom the marginal benefit may be much more significant given the likelihood of developing more severe disease. So I'm using a framework that's been developed by a group of pediatric infectious disease physicians and pharmacists led really by Katie Chiodos, who's an infectious disease and ICU physician at CHOP. But I think these are some important treatment considerations when we're thinking about children and making decisions about whether to use therapeutics and if so, what. So the first one to focus on is illness trajectory. So we know the natural history of COVID-19 is really in sort of two phases, more or less. We think in the beginning, we have a lot of pathology that's driven by the viral infection itself. And that over time, in those patients who do not spontaneously recover from their infection, there may go on to develop a much more hyperinflammatory phase of illness, which is being driven mostly by the host response. It's important to think about where someone is in the stage of illness because the therapeutics may be more helpful at certain stages than others. We're going to talk about this when I kind of dive into each of the different therapeutic categories. But for example, if we think we're in the early stage of infection, we probably want to try to think about the use of an antiviral medication that's going to mitigate propagation of the viral infection. Whereas if this is someone who has a much more established infection that's being driven by significant inflammation and is more being driven by the host response, we want to think about a different category of medications. This sort of blends into the idea of illness severity. And this is particularly important, as I've mentioned a number of times already, because we know that most children are going to develop either asymptomatic or mild to moderate infection. And I put these definitions here because they end up being used across several different studies. And so I think it's helpful to have in the back of people's minds. Obviously, someone who's asymptomatic has no symptoms. And in fact, I would argue that a number of the COVID-19 infections we have seen at Lucile Packard have been picked up incidentally in asymptomatic patients. Then we move on to patients who have mild to moderate illness. They may have upper respiratory tract symptoms, things like runny nose or congestion, but there's no need for oxygen or there's no increase in a baseline oxygen requirement. Radiographic findings in COVID-19 among children are relatively nonspecific and may or may not be present in a patient who has mild to moderate infection. We then go on to see patients who have more severe disease, which is defined as having a new or increase from baseline oxygen requirement. And then we have patients who may go on to develop critical illness, where there's a need for invasive or non-invasive mechanical ventilation, or in patients who are presenting with sepsis or multi-organ failure. Again, depending on the stage of illness, some therapeutic interventions may be more helpful than others. And in the majority of children who will be caught at an asymptomatic or mild to moderate stage of illness and who are predicted to recover, I've put here a list of medications that may be more beneficial. And then for the patients that go on to develop more severe or critical illness, the category of medications we might be thinking of in that patient population. The next consideration is the hypothesized risk factors for poor outcomes. So who are the patients that we think are going to benefit most from the interventions that we're offering? This has been studied nicely in adults, and a couple of risk factors have really emerged as important. In particular, age. Older patients are at much greater risk for severe disease. Again, severe disease being defined as patients who require hospitalization with hypoxia and an oxygen or oxygen requirement. We also know that patients with obesity and with an elevated BMI are at significant risk. And interestingly, this is emerging data, but it appears to be it appears that men are also at much more increased risk for severe disease than women. And I've listed a few other potential risk factors for severe disease as listed by the CDC. I would put a gigantic question mark on what the severe disease risk factors are for children. It's been hypothesized that there might be similarities as we see with adults in terms of children who have obesity or medical complexity for some reason. But it appears that even in several of these subcategories of patients, the patients, when they're children, do quite well, even if they have one of these underlying conditions. And so we're not and cannot be totally certain what the risk factors for severe disease are in children, which makes identifying the populations who we think would be at greatest benefit from these interventions very challenging. Medication availability is a very important consideration. I don't have separate slides for this, but I think it's worth mentioning that medication availability can be challenging based on whether this is a medication that you have in an abundant supply. And as example of that, I'll use Remdesivir, which at this moment in time, we see no shortage of, versus a medication where the supply is extremely limited, where it's being used under an emergency use authorization, something like bamlanivimab, where you have to have a different calculation in terms of allocation of these scarce resources. And then the last consideration is the strength and the applicability of available evidence, particularly in pediatric patients, where, as Alan mentioned, there's very little pediatric data. So to walk through the potential therapeutics, this is just, these are 4 of hundreds of potential therapeutics that have or are currently being investigated, but I think this is where most of the data lies and where I'm going to focus the talk today. So to start out with, I wanted to give just a little bit of history about Remdesivir. So Remdesivir was initially created and developed by Gilead in 2009 as a potential treatment for hepatitis C and potentially for RSV. It turned out not to be efficacious for either of those viral infections, but then was repurposed as a potential treatment for Ebola. And on the right-hand side, you see a map. This map is to give you a reminder for those of you who were around at the time that back in 2014, 2016, there was an Ebola outbreak in Guinea, began in late 2013 before spreading to neighboring countries. And it really increased the urgency for identifying therapeutics that could potentially be repurposed, like Remdesivir, for the treatment of Ebola. So after looking at in vitro activity of this agent, where it was found to inhibit a number of different viruses with very low cytotoxicity and some initial in vivo studies in non-human primates, there was the hope that this is something that could be rolled out for study in humans. Just so people are aware, what does Remdesivir do? What is its mechanism of action? I've distilled it here for you. I am no virologist, but to sort of give you a sense of how Remdesivir works, it's basically a nucleotide prodrug. It's metabolized to a pharmacologically active nucleoside triphosphate metabolite after being distributed inside of the cells. And then that Remdesivir triphosphate acts as an adenosine triphosphate analog and competes for incorporation into RNA chains by the SARS-CoV-2 RNA-dependent RNA polymerase, which ends up resulting in delayed chain termination during viral RNA replication. Very wordy. So they had hoped that this was a medication that could be used as an effective treatment for patients with Ebola. There was an outbreak of Ebola, as we mentioned, but the Ebola outbreak actually ended before this drug could be used. And so it ended up being used in a handful of cases, basically on a compassionate use basis. One for a nurse, a UK nurse who actually developed a relapse of her Ebola infection, and then was used on a compassionate use basis for a young child, but really was not able to be implemented in a study. There ended up being a second Ebola outbreak, a subsequent Ebola outbreak in the Democratic Republic of the Congo in 2018. And so once again, Remdesivir came up as a potential therapeutic agent. This time, there were sufficient number of patients as a part of the outbreak to have a randomized controlled trial to look at whether Remdesivir may be helpful for Ebola virus disease. Remdesivir was compared to a control group called ZMapp, and this is a monoclonal antibody, as well as two other monoclonal antibodies that had been in development to see whether there were lower rates of death at 28 days. And any patient of any age who was positive for Ebola virus by RT-PCR was eligible for enrollment in this study. So this is the first time they were able to actually test the hypothesis that it might be helpful. Unfortunately, there was a DSMB interim analysis of the data from 499 patients, and they ended up recommending terminating of the random assignment to either ZMapp or Remdesivir because of data that suggested that individuals who had low levels of Ebola virus in the blood had a greater chance of survival if they received one of these other two monoclonal antibodies, either MAB114 or REGN-EB3, as shown on the survival curve. So it did not look like Remdesivir was going to be the answer for Ebola. It did not stop people, though, from investigating the potential use of Remdesivir for a variety of other viruses, and specifically coronaviruses. It was found to have in vitro and in vivo activity against SARS-CoV, the original, as well as circulating contemporary human coronaviruses, our sort of common cold, and MERS-CoV that had emerged. And, you know, was being studied actively by a number of different centers as a potential agent for one of these infections when SARS-CoV-2 emerged in China. Very, very quickly, and the rapidity of this is really quite phenomenal. There were in vitro studies performed, which did confirm that Remdesivir had at least in vitro activity against SARS-CoV-2. This was followed up with in vivo studies, just one of which was done in rhesus macaques, and did find that there were decreased signs of respiratory disease, pulmonary infiltrates, decreased virus titers, decreased lung damage, really looked very encouraging. Although interestingly, no difference in virus shedding from the upper respiratory tract if you were to do like sequential and serial PCR sampling. But on the basis of this data that was emerging in animal models as well as the in vitro data, this drug became available for compassionate use from Gilead on January 25th. And what I'd like to do now is just walk through some of the clinical trials that have shaped the way that we think about and use remdesivir. The first one is the ACT-1 trial. And the way that I'm going to walk through each of these is by walking through the study design, the study population, the results, the conclusions, and the limitations. So the ACT-1 trial is an NIH-sponsored, double-blind, randomized, placebo-controlled trial. It enrolled and included 541 patients in the analysis who received remdesivir, and then 521 patients who received placebo for up to 10 days. What I've tried to highlight here are some of what I think are some of the more pertinent things to consider. So for example, ACT-1 did not enroll any children. To be eligible for participation, you had to be at least 18 years of age, have laboratory confirmed COVID-19, hospitalized, and then have some evidence of lower respiratory tract infection. As a result, most of the patients had severe disease. And as a friendly reminder, these are patients who are either hypoxic or have an oxygen requirement. As you could imagine, this population skewed very old, and there was a slightly more men in this study than women. I do want to point out, and I think this is worth mentioning, that there has been a lot of attention paid as of late, and I think this is important to call out in these studies, to the social and structural causes of healthcare disparities. And part of this is underrepresentation of minority groups in COVID-19 clinical trials. So for your reference, I've included in here the non-white populations that were included in each of these studies. In this particular study, most patients had at least one comorbid condition, such as obesity or diabetes. And importantly, the median time from symptom onset to randomization was 9 days. And as I mentioned, when we're thinking about antivirals, we probably want to think about using these as soon as possible because we want to catch this when the disease is being driven mostly by viral replication and not the host immune response. In terms of the outcome, the authors of this study were interested in looking at the median time to recovery. And it's important to point out that ACT-1 and two of the other trials I'm going to mention basically developed a ordinal scale where there are different categories of severity of illness. So for ACT-1, it was an 8-point scale. If you were a 1 on the scale, that meant that you were discharged and really had no complications related to COVID-19, whereas if you were an 8 on the scale, that represents death. And what they were looking for was time to recovery, which was defined as the first day within that 28-day period after enrollment in which they met the criteria for categories 1, 2, or 3, meaning that they were discharged or were in the hospital, but only really for infection control issues and not because they needed any further care related to COVID-19. And what the authors found was that the median time to recovery was indeed faster in the group of patients who received remdesivir, 10 days versus 15 days, which was statistically significant. When they looked at the subgroup of patients who would benefit the most from remdesivir, it was clear that patients who were on low flow oxygen, so patients who were on nasal cannula oxygen, let's say at 2 liters, benefited the greatest. And again, this makes sense because this is a population of patients who are probably earlier in their illness versus a patient who requires non-invasive or invasive mechanical ventilation. There was also a survival benefit in this low flow oxygen group, but overall there was no difference in mortality by day 29 when comparing patients who got remdesivir and those who got the placebo. So in conclusion, the authors found that remdesivir was superior to placebo in shortening the time to recovery in adults who were hospitalized with COVID-19 and had some evidence of lower respiratory tract infection. Importantly, the study was not powered to look at differences within the subgroups of disease severity, although they did find a signal that potentially the low flow oxygen patients did better. And the ordinal scale that I've described to you was something that was developed as part of these studies, but may not be clinically relevant when we're thinking about time to recovery. The next study I wanted to talk about, it was called Simple Severe COVID trial. This was a Gilead-funded randomized open label trial that compared remdesivir for 5 days versus remdesivir for 10 days. In this case, and I think it's something that Gilead should be applauded for, they did enroll patients down to 12 years of age. These are patients with lab-confirmed COVID-19 and severe disease. So this is patients with an oxygen requirement or hypoxia, but importantly, patients who required mechanical ventilation or ECMO were excluded from this study. That meant that most of the patients were actually on low flow oxygen, or by the time of actually receiving the drug, no longer had an oxygen requirement. The median time from symptom onset to the first dose of remdesivir was 8 to 9 days, similar to the ACT-1 study. So again, this is a little bit later in the course of illness than maybe optimally for patients who would benefit from remdesivir. In this case, the authors were looking at the distribution in the clinical status on a similar ordinal scale, although I'll point out it was actually inverted at day 14. And what they found was that basically, whether you got the 5-day or the 10-day course of remdesivir, your likelihood of having an improved clinical status was similar. The time to achieve clinical improvement of at least 2 levels on this ordinal scale was also similar between the two groups, and there was a similar rate of mortality. So in conclusion, patients who had severe COVID-19 but did not require mechanical ventilation did equally well whether they got 5 days or 10 days of remdesivir. Again, studies or limitations rather for the study include the fact that it was open label. There was no placebo control, which makes this study a little bit challenging to interpret. And then I think it's also important to point out that there were baseline imbalances in the clinical status of participants. So patients in the 10-day remdesivir group were actually slightly worse in terms of their baseline clinical status than the patients who were in the 5-day group. There was a subsequent study or parallel study, also Gilead sponsored, called Simple Moderate COVID. Again, this was randomized and open label. This time there was a standard of care group, but there was still a group of patients who were given 10 versus 5 days of remdesivir. Importantly, these are patients, though, with moderate disease. And again, this did enroll patients down to 12 years of age. Still skewed to be a very elderly population, median age or older. Elderly is probably not fair, but an older population with patients having a mean age in the 50s. Again, we see this consistently across studies. About 60% of the participants were men. The median time from symptom onset to first dose of remdesivir, similar to the other two studies, was about 8 to 9 days. Importantly, standard of care was driven largely by what standard of care looked like at the center that was enrolling the patient. And these patients were more likely to get another agent outside of remdesivir. That might be something like tocilizumab or dexamethasone. In this study, remdesivir for 5 days did have a significantly higher odds of a better clinical status distribution. So again, the likelihood of moving up favorably on that ordinal scale by day 11 was higher in that 5-day arm than in the standard of care group. Interestingly, the clinical status distribution at day 11 for the patients who got 10 days was basically the same as patients who got standard of care. There were a lot of hypotheses about why this might be. Part of the thought about this is that, remember, we're looking at where the patient was on day 11. It's thought, and if you go back and look at the data, several patients were kept in the hospital to complete their course of remdesivir, even though as part of the study, if they were otherwise ready for discharge, they could be discharged having not completed either the full 5 or 10 days. But if we concede that some patients on that 10-day course were potentially left in the hospital to complete the full days, they may not have been discharged until day 11. And so that may have negatively impacted where their clinical status was at that time. But the authors of the study concluded that among patients with moderate COVID-19, those randomized to 5 days had a statistically significant difference in clinical improvement. Again, this was open label. There were a number of patients who did not complete their assigned treatment duration. As I mentioned, they could have been discharged sooner. And then the ordinal scale may not be great for detecting patients with moderate COVID because it's really just looking at, do they need oxygen and or are they ready for discharge, and not potentially more subtle symptoms related to COVID. The last remdesivir study is Solidarity, which got a lot of attention. This was a WHO-sponsored randomized open-label trial of remdesivir for 10 days versus a number of other potential medications that had been hoped to be efficacious for patients with COVID-19. The study population was only patients over 18 years of age. These patients had to be hospitalized, and the vast majority of these patients were over 50 years of age. 63% of the patients in Solidarity were on oxygen, and a small fraction of these patients were also ventilated. Unfortunately, Solidarity didn't give us a lot of granularity in terms of the patients at baseline, and so when we're told they're on oxygen, it's unclear whether they're on low-flow oxygen, whether they required non-invasive ventilatory support. Most patients were randomized on hospital days 0 to 1, but again, the Solidarity study did not tell us how long they had been symptomatic before they started Remdesivir. However, importantly, this study was actually powered to look at mortality and found that the overall 28-day mortality of 12% was not significantly different between standard of care and any of the arms, Remdesivir, Kaletra, Hydroxychloroquine, or the interferon arm. There was also no difference in the need for ventilation or time to discharge between any arms. And the authors concluded that the Remdesivir appeared to have little or no effect on hospitalized COVID-19, with no change in mortality, initiation of ventilation, or duration of hospital stay. This was an open label trial, which obviously has its limitations and an intention to treat analysis. Again, time from symptom onset to randomization was not included, and this was called out in the other studies as having been around 8 to 9 days, but you could hypothesize if patients are coming in very late, there's a very low expectation that Remdesivir would be helpful. I did want to just talk a little bit about the controversy related to the Solidarity study. For the conspiracy theorists among us, I'll present this without comment, except to say that Gilead knew about the Solidarity trial results showing no difference in mortality on September 23rd. The manuscript was also sent to Gilead, although it was heavily redacted per Gilead, and it's unclear exactly what data was presented. Shortly thereafter, the European Union signed a $1.2 billion contract with Gilead for 50,000 courses of Remdesivir at €2,000 per course. And a day later, they were made aware of the Solidarity trial results. So clearly did not have all of a full picture about what Remdesivir could or could not do before making that contract. A preprint for the Solidarity trial was uploaded to the internet on October 15th. And a week later, this drug was approved by the FDA and remains the only drug approved for COVID-19. It's not clear how much information the FDA had related to the Solidarity study prior to making the approval of this medication. So where are we now? It is FDA approved for use in patients over 12 and over 40 kilos for the treatment of COVID-19 that requires hospitalization, and it is the first agent to receive approval. There's also a revised emergency use authorization with criteria that I've outlined here. So the next category of drugs that people had looked to as potentially being helpful are corticosteroids, and wanted to spend a little bit of time on those. As I mentioned earlier, we know that some patients with severe COVID-19 have significant lung injury and multisystem organ dysfunction that's thought to be related to the host immune response and not just to the virus itself. It's hypothesized that corticosteroids may prevent or mitigate any inflammation-related pathology. So perhaps this is a population that would benefit from this category of medications. There is a very mixed track record for the use of corticosteroids for other viral respiratory infections, as I've included down here. The bottom line is that there isn't really any clear signal that they're beneficial. However, it makes a lot of sense to think that these might be helpful for patients with COVID-19, and I wanted to present the results of the recovery trial. This is a randomized open label study that compared standard of care versus standard of care plus either oral or IV dexamethasone for up to 10 days in patients of any age who are hospitalized with clinically suspected or laboratory confirmed COVID-19. The majority of patients, as you see, did have laboratory confirmed disease. About 16% of patients were ventilated and 60% of patients were on oxygen at the time of enrollment. The median duration of treatment was 7 days. Again, I should mention this was up to 10 days, but could be discontinued earlier. Remdesivir was an option because, again, this was standard of care plus minus this, and was about equal between the arms of the study. In this case, the median days from symptom onset to time of dexamethasone receipt was about 8 to 9 days. And this might be, more along the lines of where we're thinking steroids would be helpful in terms of the duration of illness. In terms of the results, it's probably best visualized with this graph. They looked at mortality at 28 days overall, and then in a subcategory of patients who required invasive mechanical ventilation, only oxygen or no oxygen. And what they found was that overall patients on dexamethasone had a lower risk for mortality. And this was being driven mostly by patients who were requiring invasive mechanical ventilation in terms of their respiratory support or oxygen. Interestingly, patients who did not require oxygen seemed to have a signal, at least, that they might do a little bit worse when they were given dexamethasone. And this is consistent with what we think we know about the mechanism of action of dexamethasone. If we give this early in the course of a viral infection, it may actually lead to increased viral shedding and increased problems because of relative immune suppression. So again, this is something that's probably most helpful in the later stages of illness. They found that dexamethasone was associated with a decrease in 28-day mortality among those with symptoms greater than 7 days, and also the risk for progression to invasive ventilation was decreased for those patients who had an oxygen requirement. So they concluded that in patients with COVID-19 who are hospitalized, dexamethasone decreased 28-day mortality among those with invasive mechanical ventilation or oxygen, but not among those who had no respiratory support. There are obvious limitations to this trial, particularly the scant information that we have about the comorbidities of these patients and the heterogeneity of group that required oxygen. We don't have a lot of granularity in terms of like at what oxygen level is this going to be most helpful. If you're on a little whisper of oxygen, should we be treating these patients with steroids or should we wait until it's escalating? But if we think about the remdesivir and dexamethasone data that I presented, and we look at the NIH COVID treatment guidelines, this is what has been suggested. Largely supportive care without the use of either agent for patients who have no oxygen requirement or are outpatient. The use of low flow oxygen for, rather in patients who have a low flow oxygen, so nasal cannula. The first line is recommended to be remdesivir. Consideration can be given to the use of remdesivir and steroids. And the last option would be steroids alone if remdesivir is not available. This is flipped a little bit in patients who have a requirement for high flow or non-invasive ventilation, where it's thought that steroids would be more beneficial. And then in patients with invasive ventilation who are probably further along in their illness, this is a patient population that would benefit greatest, more than likely from steroids, but that remdesivir could also be considered, particularly if they're recently intubated and you think they're relatively early in the course of illness. The next category of medications is monoclonal antibodies, and I think this has gotten a lot of attention recently, so I wanted to touch upon it. The idea behind this is that neutralizing antibodies are a key component of our immunity for most viral infections. We can treat patients with either convalescent plasma or monoclonal antibodies. There are pros and cons to each of these. Some of the difficulties with convalescent plasma are the difficulty in collecting this from seropositive donors who have had COVID-19 infection. And then really importantly, the variability of binding and neutralizing antibody titers, which are relatively unreliable in patients with convalescent, when using convalescent plasma versus monoclonal antibodies, when we have a better sense of that. The main targeting for most of the neutralizing monoclonal antibodies that are in development is the receptor binding domain on the surface of the spike glycoprotein that mediates entry of the virus into the cell, as shown on this cartoon on your right. You could imagine that this might be helpful for either the use of prevention of infection, such that it might decrease the length of time that someone is shedding virus, but may also be helpful for patients who have established infection to increase the ability for them to clear the virus and mitigate any damage that the virus is causing. So to touch on the BLAZE-1 trial, this was recently released data from an Eli Lilly-sponsored randomized double-blind placebo-controlled trial. In the study, they took patients who have mild to moderate disease, so relatively early in the course of illness, who were known to be SARS-CoV-2 positive with a test that had been collected within 3 days of the infusion of the monoclonal antibody. And then patients were randomized into 1 of 4 arms, a placebo arm, or different doses of bamlanivimab, which is one of these monoclonal antibodies at either 700, 2800, or 7,000 milligrams. The study included patients over 18 years of age with mild to moderate illness, and the median duration since onset of symptoms was 4 days, which is probably what we want to target for a medication like this, where it's probably better to give the medication as soon as possible. Their primary outcome was actually decrease in viral load as detected from nasopharyngeal PCR. And what they found was that really the only group who had a statistically different decrease in their viral load was the arm of patients who got 2,800 milligrams. But in fact, by day 11, which was their endpoint, most patients had cleared nearly 100% of the viral RNA that could be detected. They did also look at rates of hospitalization, and I put that in quotes because it's important to note that hospitalization also included the patient being seen in the emergency room. This was a composite outcome, but they did find that by day 29, about 1.6% of patients in the bamlanivimab group versus 6.3% in the placebo group required hospitalization or were seen in the emergency room. It did appear on a subgroup analysis that patients who were over 65 or whose BMI was greater than or equal to 35 benefited most from this intervention. They concluded that one of their 3 doses of bamlanivimab appeared to accelerate the natural decrease in viral load over time. The other doses had not, but there seemed to be a signal that patients were less likely to require hospitalization, at least in this high-risk category of patients. And I don't know that I explicitly mentioned this, but it's probably worth mentioning. These were patients who were thought to be at high risk for severe COVID-19 infection. Limitations include composite outcome of this hospitalization and emergency room use, the heterogeneity of how they defined high risk, which I'll talk about on the next slide. And it's important to point out that this drug was also studied for inpatient use in patients who have already been hospitalized as part of the ACTIV-3 trial and was found not to be effective. So in response to this data, very quickly, shortly thereafter, an emergency use authorization was granted for bamlanivimab by the FDA with the following criteria. This is for outpatients with mild to moderate COVID-19, over 12 years of age and weighing over 40 kilos. I will ask people to recall that the data we have available is only for patients 18 and over. The BLAZE-1 trial is still enrolling patients and has now dropped their criteria to 12 years of age and older, but the data that has been made available as part of this interim analysis only includes patients over 18. And prioritizing high-risk patient populations who may go on to develop severe COVID. I wanted to touch briefly on hydroxychloroquine and azithromycin because early on in the COVID-19 pandemic, these got a lot of attention. Hydroxychloroquine is an analog of chloroquine. It has been approved by the FDA for malaria and for autoimmune conditions, including things like lupus. It had some biological plausibility for use in patients with COVID-19, including both antiviral activity in vitro systems and its known immunomodulatory effects, which are leveraged for patients with autoimmune conditions. It first got attention based on a preprint that was published from a group in France, which suggested that patients who received hydroxychloroquine or a combination of hydroxychloroquine and azithromycin tended to clear their virus much more quickly than patients in a control arm. There were several limitations and issues with this study, and anyone who's on Twitter or is interested could find some more of the banter that was related to this preprint. But it was released on the internet in mid-March and got a lot of attention. Our favorite infectious disease specialist, Elon Musk, started the conversation early on March 16th on Twitter. Maybe it's worth thinking about chloroquine for COVID-19. Donald Trump chimed in shortly thereafter. Hydroxychloroquine and azithromycin taken together have a real chance to be one of the biggest game changers in the history of medicine. It got a lot of attention in the media. Study finds positive results from hydroxychloroquine all the way to hydroxychloroquine saves lives. An EUA was subsequently issued on March 28th based on the preliminary data that had become available before we started to see the breaks on this medication. So we know hydroxychloroquine prolongs QTC. We know that risk for QTC prolongation is exacerbated for patients who are on a combination of hydroxychloroquine and azithromycin, as was suggested by that other study. And the FDA actually released a drug safety communication in late April, indicating that this combination really should not be used outside of a clinical trial. Subsequently, data started to come in from various randomized and observational studies, as I've listed here, that essentially, if we were to distill it, found no benefit to the use of either hydroxychloroquine alone or hydroxychloroquine in combination with azithromycin for either hospitalized patients, outpatients, or as post-exposure prophylaxis. As a result, the EUA, the emergency use authorization that had been issued at the end of March, was actually revoked in mid-June, and the NIH treatment guidelines recommend against the use of chloroquine or hydroxychloroquine with or without azithromycin for either hospitalized or non-hospitalized patients with COVID-19. But I think this is a very illustrative example of the rapidity and the quality of data that we have relied on in terms of thinking about the therapeutic options for COVID-19. I have not even begun to skim the surface of all of the different potential therapeutics that people have investigated and or are investigating. Two that have come up and I think have been largely debunked are ivermectin, an anti-parasitic medication, and lopinavir-ritonavir, which is used for patients with HIV infection. There's pretty good data that neither of those is probably going to be a silver bullet for patients with COVID-19, but there are many, many other potential therapeutics that are being investigated at this time. Wanted to end very quickly by just reminding everyone that an institution-specific algorithm was developed when thinking about the management of patients with COVID-19 and therapeutic options. I know this is probably projecting relatively small, but it is available on the intranet for your reference, and walks through the different stages. Again, I think it's important to point out that all of this starts with the severity of illness and whether the patient is asymptomatic, has mild to moderate disease, severe illness, or critical illness. And then we've put in suggestions about the use of dexamethasone and remdesivir, including the multiple different routes by which remdesivir could be procured for your patient. There's also a backside to this algorithm, just so people are aware, which has a lot of information that walks through the different allocation and procurement processes for these different therapeutic agents relative to our process here at Lucille Packard. I just wanted to thank everybody again for the opportunity to speak. This is U.S. Antibiotic Awareness Week, so I cannot close without putting in a plug for the Antimicrobial Stewardship Program and our phenomenal team, including Laura Bio and Lauren Puckett. And please do follow us on Twitter. It looks like I was able to make it through with some time to spare, and I'd be happy to answer questions that anyone has. Thank you.
Wow. Yeah, that was a tour de force, Hayden. Well done. And I don't know how much everyone realizes how frequently you guys get called by us and referring providers to help answer a lot of these questions. Well, Rodney, I'll take this. I want to combine. There was a question about you, Hayden, alluded to the fact that the Gilead Remdesivir trial did include kids 12 and over, and someone was asking, Annalyn was asking if you happen to know how many kids actually made it into that trial, or if you have a gestalt, and if so, whether we know if they did a subgroup analysis on the kids.
Yeah, that's a really good question. So I don't think there were very many children. If you take a look at the median age and the interquartile range for those studies, as I mentioned earlier, it skews pretty old. These are patients who are mostly in their 50s and 60s. There was no data that I could find that looked at the pediatric population specifically. However, there is another study called Caravan, which is looking specifically at children 18 years of age and younger, and the use of remdesivir. They're looking at pharmacokinetics, pharmacodynamics, and efficacy. It's sort of like a 1, 2, 3 trial. And there are several study sites that are enrolling pediatric patients for Caravan. It will be really interesting to see what that data looks like, because I think that's our best chance of understanding the efficacy and what role remdesivir has for children.
And can I just stay with remdesivir for a little bit? How do you reconcile the differences in the findings between the Gilead trial and the World Health, the Solidarity trial? I mean, even in the Gilead trial, there was the effect size for mortality was quite impressive. It was not quite statistically significant, but I think there was a 4% absolute risk difference. That's pretty real. And then obviously the time to recovery was a lot faster. And then you see just really no signal at all in Solidarity. How do you reconcile those?
Yeah, I think that's a great question. So I think the first thing I'd say about Solidarity is we don't have a lot of granularity for the data, right? So we have this group of people who required oxygen, and we know nothing really more about that group of patients because we don't have a sense of the level of oxygen requirement that they had. We don't have any sense of how long the patient was symptomatic before they actually received remdesivir. And I really, truly believe that the earlier you're able to intervene, the more likely you are to see an effect, whether that's improved clinical status or mortality, frankly. There were a lot of differences in the way these studies were actually performed and the way they were powered, right? Like Solidarity is a huge study. It was powered to look at mortality. If we look at the simple trials, far, far fewer patients and really powered to look at this clinical improvement on that ordinal scale. So I think there's fundamental differences between the studies. There's a lot of unanswered questions, I think, and the Solidarity trial, by the way, has not been published. This is all preprint. It has not been peer-reviewed. I think there's a lot of, potential subsequent analyses that will need to be done before we can really compare all of these studies to one another and have a sense of, where that signal is. I think it's a really important and interesting question. I just think it's unresolved with the data that we have right now.
And I just want to add thank you to Hayden as well. That was super impressive, detailed review of all the high impact trials. And I know that there have been some compliments on this. And if anyone does wish to see this later, it will be available through our recording. This is an interesting question. There were prior recommendations to using anakinra and tocilizumab. I remember that time as well, seems like a long time ago. So where does Stanford stand on this?
Oh, that's a really interesting question. So it's funny because I think some data just got released this morning that was some of the first positive data that I've seen for tocilizumab. Obviously, a lot of these immunomodulatory medications got a lot of attention as potential therapeutics for COVID-19, especially patients who are in that sort of later stage of illness that might be driven by more of a hyperinflammatory response. Most of that data has not shown these agents to be particularly effective. Certainly there is almost no pediatric data, so I can't really speak to what the role, if any, is for these agents in that patient population. The last I checked, from looking at what the adult hospital is doing, they were also not enthusiastic about the use of these medications. Again, I did see something just this morning that was suggesting there may be some positive data from a trial for tocilizumab, but I don't know much more than that. And so what I would say right now is that we have not used those medications, and I don't think that there has been extensive use based on the data that has been published so far.
The question just popped up about the effectiveness of colchicine. Can you talk about that?
Yeah, I don't know a lot about colchicine. I know that it is being studied, but I'm afraid I can't comment much further on, the role, again, if any, that it would be playing. I have not seen it used in children. I'm not aware of, any data regarding colchicine. There's a lot of different agents that are out there that are being studied right now, but I can't comment specifically on that one.
Then let's talk quickly about the monoclonal antibodies, and we were discussing this a little bit before we got started today. This narrative that they need to be started early seems like for you guys you're going to be fielding a ton of questions about that. Someone gets a cold, maybe they're immunocompromised, the COVID tests aren't even back yet, or maybe they just came back, they're generally doing well, they don't need to be hospitalized. How are we going to approach this issue of early treatment in kids that have the potential to get sick but maybe aren't quite sick enough yet?
That is the million-dollar question, Alan. This is going to be a very complicated question. I'll start by saying we have zero data for patients under 18 years of age. They are now enrolling patients 12 and over, but we have no data to date. We also know that most patients 12 to 18 years of age, even patients who have quote unquote potential high risk factors for developing severe disease, will do okay. Obviously, there's probably a subpopulation as yet identified of patients who will fare worse. You could imagine a patient population that would benefit from a monoclonal antibody, right? So maybe this is like a patient who is aplastic, has no humoral immunity, does not have any B cells, is not going to be making immunoglobulin. So those are, that's a patient population where you might anticipate if you can get to this drug to them early enough, it may be beneficial. But then you come into the question of, okay, let's say we can sort out who the patients are that we want to give this to. The logistical considerations are significant. I mean, it's a heavy lift. I can tell you we, as a hospital, are exploring a lot of different possibilities. There have been discussions with Stanford on the adult side in terms of trying to align our process as best we can with them. Thinking about, is this something where we want COVID positive patients? poor Roshni from an infection control perspective. Do we want COVID positive patients coming in to the hospital? Do we want these patients coming into our infusion centers? Because this is a medication that does have to be given over an hour. The patient has to be observed for an hour afterwards. And by the time you've included registration and everything else, you're basically looking at a 3-hour, event to give them bamlanivimab. So this is not just like an injection of ceftriaxone. This is a much more complicated process with lots of infection prevention and control implications and lots of logistical issues. Not the least of which is that it has to be given as an outpatient and is not really intended for inpatient use or for patients who require hospitalization. That, in my mind, brings up a lot of resources, issues related to resources and equity, frankly. Like, are the hospitals with tons of resources going to be the hospitals that are able to pull this off? But are your clinics and centers in more underserved areas who don't have the capability to do a 3-hour infusion in their infusion center not going to be able to offer this medication? Just lots of really lots of implications related to bringing this medication online, and again, really untested. And I'd point out, sorry to belabor this, but even in the patients 18 and over, we don't really know who the category of patients are that would benefit most, right? Like, there's just this broad, high-risk category that includes everything from patients with hypertension to patients who are profoundly immunocompromised. And I think we're looking for more data to help us understand who are the patients that are really going to benefit most. Is it that 18-year-old aplastic patient, or is it the 75-year-old patient with hypertension? I mean, there's arguments that could be made, I think, for a variety of different populations in terms of prioritizing a medication that really is in scarce supply.
All right, well, go ahead, Raji.
I think we've run out of time. There was a question about using dexamethasone and about how it could blunt the immune system. I think all of these are great questions and clinical conundrums when it comes to actually dealing with it at the bedside. Always interesting. But I think we have to wrap it up now. Thank you so much, Dr. Schwenk and Dr. Joshi, for that excellent presentations. We will take a break next week for Thanksgiving. Stay safe, everyone. There are mandatory rules now about what you can do in purple tier. So review that, at least in California. But we just want to thank you for listening, and we will meet again on December 3rd.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.